Welcome to the Eye of the Needle podcast, where we discuss healthcare innovation and explore how visionary entrepreneurs and change leaders are reshaping the future of our industry.
Welcome to the Eye of the Needle podcast. I am your host, Pam Arlotto. We have spent, as an industry, billions of dollars digitizing healthcare. Yet most of us still struggle to access our medical record and to get a true picture of our health. Many of us in the industry have worked for years on these challenges, and we often wonder, what is working? Where have we missed the mark? And what can we do differently in the future? Today, we're joined by Kristen Valdes. She is a healthcare visionary on a mission to make whole person care a reality. She's going to help us unravel the mess of our data silos, show us what's working, and challenge us to rethink who should really be in control of our healthcare information. Kristen is CEO and founder of b.well Connected Health. She has gotten so many awards in this industry. It's so impressive. She has been named one of 4 women transitioning industries by Accenture and Springboard Industries. A few months ago, she was recognized by Inc. magazine in their top 2025 female founders list. And on May 5th, she will be presented the Nexus Award for Leadership in Care Transformation by the American Telemedicine Association. All phenomenal. Kristen, welcome to our show.
Thank you so much for having me.
It's great to have you. And I know so many people have heard you tell this story. In fact, I heard it at Vive and had heard it before, but it really kind of grabbed my attention as you told it. Your journey in healthcare innovation began as a mom fighting for answers. And for those of our audience members who haven't heard your story, could you go back to that experience with your daughter and why it led you to ultimately found the company?
Yeah, I'd be happy to. So, like most moms raising their children, you tend to have a sixth sense when something's going on with your babies. And by the way, my baby is now 21 years old and graduating from college next month. So we're incredibly excited about that. But, raising my kids, my daughter was always sick. She wasn't severely sick. She was just oddly sick. So it was interesting because, as a parent, you take your kid to doctor after doctor after doctor. And we were largely just dismissed because she wasn't sick enough to be hospitalized. But they couldn't really describe things that were going on with her. And it was interesting because I just felt like I was consistently dismissed as writing things off to family health history or, things that just didn't really logically make sense to me. And when Bailey was about 7 years old, she was hospitalized for the very first time and nearly lost her life because 2 electronic health record systems couldn't talk to each other. And it was a result of a standard routine medication prescribed by a pediatrician for a sinus infection, something that would happen every day in our kids' lives. But that EHR system couldn't talk to a specialty system that for the first time had run the labs and had diagnosis codes associated with Bailey's care that I was unaware of. And that specialty system didn't have a patient-facing portal. So Bailey was the recipient of a drug to disease contraindication. And so that contraindication resulted in her body nearly killing off all of its own blood platelets. And so she was hospitalized. And it was at that point that I became a little bit of a mama bear. And I always describe our mama bears because there's a lot of them in healthcare who have started companies as a result. But it really challenged me to go out and try to figure out what's the entire clinical picture around Bailey? And what did I miss? Or what could I have seen? Or what could I have said differently to the doctors? And the first thing that I had to do in order to encounter and really go through that journey was to collect her medical records. Mm-hmm. And that's one of the most difficult things that I've ever done. It took over a year. I was given the runaround, bad information, a lot of misinformation, people telling me that because she was under 18, she didn't have the right to her medical records, which of course was false.
That's not true.
Just a lot of misinformation by office staff and physicians. And And believe it or not, the doctor that had delivered Bailey had retired. So I never was able to recover those records because while they were required to be kept for over a decade, they were in a warehouse somewhere with nobody having access to the key or information on how to go get them. And so, throughout Bailey's journey, I was able to collect enough of her information. I used to call myself the Excel lab plotting mom, right? Trying to create trend lines, because even when you could get access to portal or information, there was no ability to trend that information over time and see what was changing or how frequently episodes were occurring or how often she was getting sick or symptoms that would show up every single time. And so I took all of her records and I created them into longitudinal trend lines. And at that point, I de-identified her data. I sent it to a number of different physicians. And 9 out of 10 of those physicians, seeing that pattern, would have recommended the test that ultimately diagnosed her. So we spent 7.5 years going up and down and in and out of systems where, obviously she was suffering, but we just couldn't, the information being locked up delayed diagnosis in my daughter's case, and technology systems not working together nearly killed her. And so 10 years ago, I launched b.well, actually named for my daughter, Bailey. I've called her B since the day she was born, as a way to do just that. I wanted to empower every family with the access to collect their longitudinal record. Now, over the last 10 years, we've obviously modified quite a bit, and we do substantially more than that. And 2 years ago, Bailey actually had another health event where she was, we lived inside of the hospital for about a year, in and out.
Wow.
She was officially diagnosed rare disease. But I'll tell you, the science of medicine blew my mind. She went into NIH level advanced genetic research. They were able to match her from a precision medicine standpoint to the exact drug that saved her life this time. Only it's an off-label use of the drug. And so a lot of what we talk about and what we'll talk about today is how the science of medicine has just so far surpassed the administration of healthcare delivery.
Right, for sure. And you mentioned precision medicine, and I know that is a goal. We often talk about that as the ultimate destination in the industry, but it's very, very difficult and does rely on that data connectivity that you mentioned. And as you've built out b.well, and for our listeners that aren't really familiar with the company or what it does, how does this company solve those very problems that you previously encountered navigating the healthcare system, but also kind of where you see it going regarding precision medicine in our future?
Yeah, absolutely. So we set out to solve the problem of interoperability and allowing consumers and their families to have access to their entire longitudinal record and the ability to share that downstream with anyone that they feel could add value in their healthcare journey. We advanced into, and I always like to say we solved for the fragmentation of data. And now we've added on the fragmentation of solutions, because I truly believe that access is the war to be won right now. And so we'll talk a little bit about how we do that. But as the unlocking of this data and access to the data, which is becoming more and more important, especially now with tools like Gen AI, which have the ability to unleash and unlock all kinds of advanced clinical detections, being able to determine people and group them similarly to people who are on the same off-label use of the drug. And I'll give you a good example. Bailey's pediatric geneticist, who I am in awe of. When I talked to her most recently, she said, you know what? She said, I know that Bailey has always been this N of 1. And while she might be the oldest and the most severe that we can find, she said, I've been collecting little Baileys. And I said, tell me what you mean. And she said that they have identified, when Bailey was 7 and we ultimately got her diagnosed, she was diagnosed with early onset lupus. Lupus is not common in pediatrics, although I think it actually is. I think it's just not diagnosed until adulthood. But from her perspective, what she learned through all of her genetic screening was that children who are diagnosed with early lupus, and I mean at the age of 2, 3, 4, where Bailey had clear myellar rashes at the age of 2. So she's had it active pretty much since birth, that each one of them in their genetics has a complement deficiency. And so these are things that we can only recently start to see. And so there's, genetics around, C1, C2, C3, C4, so complement deficiencies, that each one of them had that and presented with early onset lupus. And then every single one of them had very severe inflammatory attacks over the course of the next year to 2 years. And 100% of them are being controlled with the drug Jakafi, which is an off-label use. It's a JAK2 inhibitor. It's the only FDA approved drug in market. And so being able to now, if we think about what data can unlock, is we can now, if we thought about adding at birth a screening that looked for complement deficiencies, we could proactively put people on this drug and they never would have near fatal events, which is how her pediatric geneticist has found all 8 of these kids.
Wow.
So having would be massive.
It's after the fact versus preventing it from happening in the first place. That's
right.
really
That's
interesting. So let's back up just a little bit. We've done so many things. The federal government is invested in the deployment of EHRs, and our industry, as I mentioned earlier, spent, let's just say, $1 gazillion or more on trying to resolve these issues. But if you could help us kind of boil down from your perspective, what are the 2 or 3 things we've done right, and then what are the 2 or 3 things we've really kind of missed the boat on?
Yeah. I mean, the first thing that we did right was probably one of my most proud moments at b.well. And that was when we were partnering with an organization called the Caring Alliance, which is a private-public partnership that works with the federal government to unleash transparency in healthcare to consumers. And so I've been on the board there for nearly a decade now. There's some phenomenal people working there. And it was when we were able to pass 2 kind of sister rules. There were federal mandates called information blocking and interoperability rules. And that was quite some time ago. But what that did was it actually required all of those EHR vendors and all payers, anybody who was a data originator in healthcare, to provide an open API to any trusted third-party application, and those are just technical terms for in-app that a consumer chooses, to allow them to pull in their longitudinal health record. And they have to do that without any special effort. And I think we got that right, because what it did was it forced the industry to do a couple of key things. One is realize that consumers can and should have access to their own health records. I mean, that's information about our bodies, right? No one's going to care about that as we do. But the second thing that it did was it actually forced these technologies, which, if you know anything about healthcare technologies, that we're sitting 2 decades behind in terms of technology. I mean, it's the internet revolution. Our entire U.S. infrastructure system is actually run on monolithic infrastructure, and so what it did was it forced them into the cloud and into modernized API technologies, which then it was recognized could be used for all kinds of transacting of data for all kinds of purposes. So those things I think we got right. What I think we got really, really wrong is that we continuously ask consumers to use logins and passwords in order to access the information. Mm-hmm. The challenge is that we're going right back to 10 years ago or 17 years ago now, when I was trying to collect Bailey's medical records. Yeah. And I had to go talk to every single office staff, because if you think about your longitudinal health record, there are doctors that you no longer see. Well, you don't have active portals with them, so you don't have a login and a password to that data. In Bailey's case, Bailey has 26 clinical patient portals. None of them are accurate. None of them talk to each other, even still today. And those that do talk to each other actually propagate bad information that you can no longer remove. And so in my daughter's case, those things are very dangerous. And so it is very frustrating that she has to call office staff and try to get a login portal and password to a doctor she no longer sees, because some of them are saying, well, you need to come in and establish as a new patient. Well, she's an adult. She can't go back to her pediatricians. Right. We've got to unleash all of this technology from portalitis. I like to say it's the diagnosis we can eradicate in our lifetimes. And that's something I think we still got wrong, but I'm very optimistic about where we're going with advanced identity, like using Clear, like you would at the airport, or an IAL2 like a biometric. It's more secure, it's more private. And I always say, if you can, board an airplane with your retina, you should be able to collect your medical records with your retina. We know that it's you. Yes,
that makes so much sense. And I've heard you say in the past that even though it was well-intentioned, HIPAA has often gotten in the way more than it's sometimes helped. Is that fair? Is that something you've grappled with?
Yes, 100%. And largely it's because, while everyone in healthcare has to take annual tests around what is HIPAA, right? It's all designed around making sure that our most coveted data, our healthcare data, remains secure. and private, and that we know what information is shareable and what it's not. The challenge is that we've become so fearful of it because of the penalties and the breaches and the bad reputational things that we have over-indexed on not sharing information. And unfortunately, what that results in is death. And I'm
Well,
very
I really truly believe it's often used as a barrier just so people don't have to do extra work. And in their mind, it's kind of like, HIPAA, can't do it. They don't even look into what they could do.
right.
So
right.
we've used this phrase whole person care. And tell me what that means and how data fits into that. Give us a little bit of a definition from your perspective.
Yeah, I mean, I think the simplest way to describe it, right, is that our healthcare system works exactly as we designed it. It is it's a sick care episodic system. When you get sick, you go to the doctor. It's very transactional. And while there's phenomenal doctors and nurses and care, it's meant to get you out of an acute episode. It is not, we don't reimburse incentives in our delivery model for whole person care. And if you think about the fact that most consumers on average today go to the doctor 1.4 times per year. But our health happens in between those visits. It happens in the food that we eat every day, in the exercise that we get. Sometimes we're not sick enough, so we don't actually record episodes that could be deemed important in our clinical journey. We don't have libraries or dictionaries or anything that allows us to even track what are the things that happen in our everyday lives? How often do we get a headache or a tummy ache or a rash? I mean, people don't realize that the skin is the body's largest organ. And oftentimes, when something is happening on our skin, it's an indication that something's happening internally. We don't have the ability to order our own labs, even if we know what general wellness labs should be with standing orders, because we're not under the care of a physician. And now what makes it worse is that when you do need to get under the care of a physician or you need a specialist, oftentimes we're waiting 6 to 9 months to get in. So you've lost the opportunity to diagnose at the point that things are occurring. So whole person health even goes beyond times where we're not feeling well. It also goes into things like where we live. What are the things that are stressors in our world? What are the habits, socially? Are we alone? Are we isolated? What are the social determinant factors that we live with? All of that plays into health and health outcomes. And we don't consider a lot of that data to be part of the medical record. And so I think that there are a number of things as technology has advanced where if you think about the advanced sensor detection in the home, right? Samsung, is a phenomenal partner to b.well. And we are powering now all Samsung users, 64 million installed phones in the US, to be able to access their longitudinal records. If you're on Android, you can get your information. But they have advanced sensor technologies in the home. If you think about how 70% of people in America have a smart TV. So if you think of the ability to connect all of the sensors and devices that are silently and could live within our lives, we could learn a whole lot more about our health, put those patterns together and get to whole person health. How are we sleeping? How many times are we, using the bathroom? Are we dehydrated? How many times do we open that refrigerator door? So there are a number of things that we can now tell and have the technologies to use that could silently alert us when there's something we should be doing about our health that we don't actively use today or reimburse for.
And AI will enable us to process all of that information. In the past, I think we've struggled with there's too much for the average consumer or patient or doctor, for that matter, to really process through. But AI is going to help us with that a lot and make that much easier to do so.
Oh, absolutely. I think in the past we've been talking about, who's going to go through all of this data and who's going to look for the right alerts and create the algorithms of who needs to be seen or not. It's not about the data. It's about the insights. And that's where AI can really play a role.
And so I guess one question I'd like to ask you, because healthcare is a lot about politics and who owns what and who's more powerful. And I think part of the reason we needed the information blocking legislation was had to do something with that power and taking that data and really, who has the data has the power. But who has it today? Who has that power today? And I guess from everything you've said so far, I would assume you think the consumer or patient ultimately should have the power regarding the use of their data. Who's got it today, and where do you think it'll go in the future in terms of that ownership and power of the data?
Yeah, it's interesting because when I went down this rabbit hole over the last decade, one of the things that I learned is that there's a very distinct difference legally between ownership and consent and use. And ownership, just like if you were to pen a book, right? You are the owner of that IP. You wrote it. So believe it
Right.
or not, our records when we're in the doctor's office are owned by our physicians legally because they wrote the note. They wrote the diagnosis. They own it. However, what information blocking and interoperability did was they allowed consumers to have the right to access. And the most important part of that legislation is that when a consumer selects to bring their data down through any application of their choosing, they're drawing their data outside of HIPAA. And that was
Mm-hmm.
probably the most meaningful part because that allowed for physicians and payers and labs and pharmacies to say, okay, I'm not going to be held, responsible from this perspective.
Yeah, it's not my problem anymore.
You took your data, and if you consent to share that data downstream for any purpose, then that's on you, consumer. You get to make those choices. I actually find this a little bit ironic. And because one of the things we talk about in our company, and it's something that we as a company hold very, very tight against, it's one of our founding principles, which is informed consumer consent. Data is never shared, it is never sold, it is never used for advertising or de-identified. And we don't provide that unless a consumer says, yeah, hey, Kristen, do you and Bailey want to contribute your data for potential clinical trial matching? We'd be like, yep, absolutely, take all our data. We're donating it to science because we're a unique family, right?
Right.
But what's interesting is the reason that data has been held on to for so long by all of these technology systems and by providers and others are what we like to call downstream dark data flows. And what that means is that they have the right to de-identify and sell your data all the time.
Mm-hmm.
But consumers are never informed that their healthcare data is out there. And when you think about the advanced technologies like AI, it is not as difficult to re-identify data as it used to be.
No, it's very easy.
We are just very, very big believers that consumers, like their credit card history, should have the ability to see a transaction each time their data is swiped. And that allows us to have better transparency and understand more. But the amount, to your point, the big entities out there, the amount of money that is paid for data in our industry is massive. It's completely undoing an entire business.
Right. And, you mentioned the credit card industry sharing that information. So often you'll hear speakers who think they're being really visionary go, oh, health data should be like banking data. And consumers have full control and ability to share that. I see pros and cons to that vision. Tell me your thoughts on that.
Well, one, it's nothing like the credit card industry. If you lose your credit card, you can get a new number and it can be replaced.
That's true.
Your healthcare data is always going to be about you. It is significantly more important to be privatized and to have security and robust security around it. And, there were provisions that were created under HIPAA around things called minimum necessary. And I still think that they're not widely used in our industry. Even transacting data on national networks between providers, right? Traditionally, when people pull information from the networks, they pull all of your history, not just what they need in this current day and time. So if you have 3 decades worth of health history and you're not in a complicating thing, but you just want to find out, did this person have this vaccine so I know whether to administer it or not? You don't need 30 years of history moving in between databases. So,
right.
I think we are very much, I think that the concept of transparency is what should be compared from a credit card industry. We can see every transaction that's ever run on our account. We can get alerts set up when something hits our account that doesn't make sense, which today, we have a $3 trillion fraud problem in this country. And do you know what part of that, part of that waste is the fact that we don't get to see every time somebody submits a bill to the insurance company, because most consumers, they're not on a portal looking at every transaction, and they don't understand what they see on there anyway. Because if you go to the hospital, you have separate bills for your physician, separate bills for your anesthesia, separate bills for your facility. So they don't know how to interpret them. But one of the things that I learned working in fraud before launching b.well was if you perform what we call a desk audit and you go out and you say, I want to look at a randomized 100 charts from this facility or from this DME company, inevitably 20% of those charts would not get returned in order to justify the payment because the visit didn't occur. It was a billing error. And if the consumer get a share of bill, i.e. a copay or coinsurance, they don't actually recognize that their insurance has been invoiced for that. So now when we think about data interoperability, there's as much advantage to businesses as there is to consumers in sharing of that information in real time, bidirectionally at scale, because we can actually start to address some of the problems that are making our healthcare delivery system so expensive.
Well, and I do believe sometimes with consumers there is an unnecessary fear. There's a fear. Let's just not call it unnecessary. Let's just say a fear of that transparency, and they want it all private, which we get that. But what type of education do you think needs to happen to make consumers and patients and their families feel comfortable about transparency, about sharing the information and making it more accessible in the purposes for their care and prevention of illness?
Yeah, there's a couple big themes in there that still cause fear. I mean, at some level, there are going to be many people that are just private. They don't want their data aggregated anywhere because they are so fearful that someone is going to take it,
Right.
or it will be used without their consent. So, education number one is your data belongs to you. No one will access or see your information without your consent. You have the right to delete it or revoke it at any point in time. They need to feel confident that they are in fact in charge and in control, just like they feel like with their bank account. Right?
Mm-hmm.
Think about the other biggest thing is that a lot of times, if you think about the fact that we have, from a commercial standpoint, our employers are the ones who are paying for our healthcare. So there's a huge amount of distrust that if employers provide solutions or apps where people can connect their data, they believe that their employer is going to get access to that data, no matter how many times you tell them.
Because they don't, right.
And they don't want it. So because they're afraid that they're going to lose their jobs if they get sick or they become expensive, because employers are now self-funding. So they know that if I get sick, I become a liability to my employer. And they know that. And they don't want to be the reason. So we have to either get away from employer-sponsored insurance and really move into an open market dynamic, just like we buy our car insurance and our life insurance and other things, right? And we need to be able to move away from that model to something that, can provide trust for people feeling like it's just them. Or we have to do a much better job with education and rights, and they have to see that there are actual actions being taken against people who use this data inappropriately that are criminal. And they don't see that today because signs are silent. And quite frankly, a lot of the rules that we've created in this country that have enforcement provisions, they are not actually funded to be enforced.
That's fair. That is absolutely fair. That makes a lot of sense. So one of the dynamics we see going on is, if you think about it, on one side, you've got a lot of disruptors trying to really change this industry. They can be from companies like yours, small startups, all the way through the big tech guys like Apple and Amazon, et cetera. And then on the other hand, you see a lot of incumbents, and that could be everything from your care delivery organizations, your health systems, your physician practices, or even some of the technology solutions like the EHR companies that support them. How do you see that kind of that yin and that yang, the incumbents and the disruptors all playing out in the healthcare ecosystem?
It's one of my favorite topics right now because, one, we're seeing more innovation in healthcare right now than we've seen in the past. And that's because of the rapid adoption of Gen AI. It is going to be transformative in healthcare, and it needs to be, quite frankly. And the innovation that I think we're going to see on the incumbent side is around making things that are incredibly painful less painful, like prior authorization.
Right.
Being able to, at scale, change some of these monolithic architectural problems we have by layering technologies on top and moving to cloud-based environments, but also being able to diagnose faster, create drugs faster, et cetera. I don't think the big tech companies are going to start there. What I get excited about with the big tech companies is that, and we've had this cliche saying in healthcare for as long as I've been in it, which is way too long, over 30 years, but is that we meet people where they are.
Yes.
And it's the most annoying phrase that I've ever heard. No, we don't. We make them come to us. And We don't meet people where they are. We're not in their home. We're not on their phones. We're not on their smart televisions. We are not wrapped into their lives the way that we need to be from a health perspective. When they're sick, they have to come navigate us. In fact, just being able to find a doctor. Do you know that 90% of search features in this country, if you go to your payer or you go to your EHR, they require you to know the specialist that you need in order to book an appointment, even if they are one of the few enabled digitally. How many
Wow.
humans do you think know what an otolaryngologist is or how to spell it? They don't.
No. Right.
They're like, I'm a
Right.
baby doctor. I have migraines. My stomach hurts. So
Right.
when you think about big tech, right, and disruptors, the small guys like us or the big guys, like the Googles and the Apples and the Samsungs, the thing that those companies know well is direct to consumer. The thing that healthcare knows nothing about is direct to consumer. So I liken the retail giants in with the big tech companies, right? The pharmacies, right? I think are going to play a really important role as we expand, their ability to participate in health because they have the footprint that is local because healthcare is localized. It needs to be convenient. So it can be convenient in person and it can be convenient digitally. But right now, healthcare is anything but convenient. And so when we think about what we need, I think that the big, giants are coming in like 800-pound gorillas and they're saying, oh, you can't see your doctor for 6 months? I can see you today. You can't get you don't have transportation to pick up your drug. I'll have it delivered through Amazon within an hour. Those are the kinds of things from a convenience of direct to consumer or what I call consumerism. Those are the things that are going to be disrupted by the big guys. And I'm here for it. I think it's overdue.
Yeah, no doubt about that. And you mentioned earlier, as you were going through your daughter's journey, the challenge of the PHR or the portal that so many of the EHR companies offer the health system today. And what do you think will ultimately happen to those things that we're all kind of clumsily using today? What will happen to those portals and personal health records in this new environment that you're describing?
So I think it's yet to be determined, but I will say that I'm incredibly inspired by the fact that a lot of these legacy EHR companies, and I think it's important to step back. EHR companies under meaningful use and were designed, the whole purpose was to digitize health records, get them off of paper, where if there's a fire, right, you lose your medical record, right? So it's just, our medical infrastructure and to advance science in a large way. But the EHR was designed for digitization of records in a point-by-point, like one-to-one interaction environment. These systems were never designed or architected to do bidirectional bulk data exchange at scale. And in fact, they don't work that way. But they did have a requirement to have a patient-facing aspect. But it was like a side note. Like in all the legislation of things that had to happen, it was a side note. Automating workflows really, really hard when you were digitizing records. I mean, the EHRs, I give a ton of credit for getting that work done. So what they did was they bolted on right now. So you have the core EHR, and then you have these bolt-on products. And each EHR is different. Some of them just have portals. Some of them have CRMs that they're bolting on. Some have life sciences type components, right? Some are now trying to bolt on products that go between payers and providers more efficiently, which I think is great, right? But it takes time to build on top of these monoliths. So when you talk about the portal, the one thing I think is going to happen is there's going to be a race. And the race is going to be between people like the big giants who are saying, I can provide a better consumer experience that's more holistic. Because EHRs, remember, are competitive. So if you have, a Cerner or an Athena or a Meditech or an Epic or others, their data isn't shared between them. And so you're never going to get a full longitudinal picture. But even if you could just get the medical record in one place in one of those EHRs, and many are trying, and I hope they continue to be successful, but they're never going to get the wearable and the sensor data and the telemedicine data and the radiology data and like all the things that happen, the pharmacy data outside of those core infrastructures. They're not integration engines.
Right.
And that's not what they're designed to be. We keep expecting, because we pay so much money for them in healthcare. If you go to any provider, they're going to say, well, you can just use my chart. But that provider cares about their experience with their patient, not all the other doctors or support systems in healthcare that also help that patient in their health journey. So we need our doctors to understand that they are failing their patients by not being more open to getting a full picture. And consumers are finally demanding it. So
and
crossroads.
I have been on a I guess, a rant lately is probably the best way to say it, that the industry is stuck in many instances optimizing those EHRs versus looking to the next level of connected care and redesign of the system of care. And it really sounds a lot like you're talking about. We've spent so much money on these things. We've got to make them do everything. And that's just really not possible. Is that fair from your perspective?
Absolutely. And it won't work because the EHR will never be everything. It just can't be. And that's okay. But we need to make it really good at the things it should be. And so by trying to make it everything, we're not focusing enough time and money on making it good at the things it should be. And that's part of the reason we have a lot of physician burnout in this country. And so,
Right.
We
Right.
make it great at what it does. And by the way, as a technologist, one of the things that's really important that I think we don't talk enough about, how can we pay so much money every single year and build systems that have some of the largest piles of technology debt that I've ever experienced?
Yes.
Why are they not required to keep up with modernized technology stacks, just like you would expect of the big hyperscalers, right? If you think about the people who are really running at AI and getting use cases live fast, they're people who were already on the cloud, who have the ability to turn on these technologies, who it's not difficult to go against these proprietary data models that are not documented, that nobody knows where the data is or how to interpret it or how it goes together, and it's considered proprietary. So, we basically took all of our most important data around our livelihood and we locked it up in a model where it's not scalable to get out without tanking the system because of how it was architected, technology debt, and because people want control of the information, which is a trust factor, and the ability to service so many. Imagine if we had 300,000 applications pinging these systems every day, trying to get every piece of information out. The infrastructure breaks down. So there needs to be legislation that talks about these EHRs, not in just meeting requirements of what they can do on a base level, but those requirements need to be advanced to keeping up with modern day technology stacks that also support privacy and security. Look at how many healthcare data breaches we had in just the last.
It's constant. It's constant. It's, as I heard one security advisor say, it's not a matter of if, but when, and it's when and when and when. It's over and over and over again. We could have a whole episode on just those topics. And I want to get back to something you talked about at the very beginning, though, because I think this is crucial. And I don't think every patient or consumer fully appreciates their own role in their health, and that it's more than just the medicines the doctor gives you, or the interventions you may get at a hospital or whatever. That there are all types of physical, behavioral, and social components to that health, and we have not done well with bringing all of that data together and learning. In fact, the stuff that happens in the biggest part of our health system, that clinical data, really is just a small percentage of the impact on health. And if you had an employer or a company, and you probably have this happen quite frequently, come to you and say, we want to kind of move toward this more integrated approach, this whole person approach. What is the very first thing they should do to kind of start that journey?
Yeah, and we get it all the time. There's such a coalition of the willing right now that makes me excited about our healthcare's future. But when health systems or payers or pharmacies or big tech companies approach us, and employers, we have them all as customers. We're unique because we service consumers, so we get to service the whole market.
Right.
The first thing that we do is we look at first of all, healthcare is a service business. Their product is data, but they are a service business. And so the first thing that we need people to understand is, what are all the services you offer? So even if you went to a health system, they have in-person care services, but oftentimes they have labs, they have pharmacies, they have virtual solutions, they have employer-facing solutions. Each one of those things that are not all run through the EHR, they're run through all different kinds of systems. We say the first thing we want to do is we want to start extracting all of that data and putting it into an open standards format. We use FHIR. FHIR, the Fast Healthcare Interoperability Resource, is the way that we are going to transact healthcare data, not just in the US, but across the world. And so we take all that data and we had to write all the converters that say, hey, I'm going to get all that data into an open standard. But more importantly, right after that, because data is going to tell us who needs what, right? That's what it's going to tell us. Who needs what? What can we learn? Then you have to create experiences that go out to those people that are conveniently fit into their lives, and they have to be personalized. The other thing people don't recognize about healthcare is we are very marketing one size fits all. Like I would say, everyone in the country does not need a colorectal cancer screening the same month of the year, right? And especially those who just had it, right? But that's how we market to people, is drip campaigns. But instead, we need real-time interactions. So I always like to say, like, my Instagram knows me better than my husband. It knows where I've been shopping. It knows what I've been in my cart. Like, it tells me and reminds me, you need this thing, or you think you want this thing. And ultimately, I get the thing, right? We're not doing that with healthcare. We have not digitized healthcare. But it's not just enough to say, hey, Pam, guess what? It's time for you to get an updated tetanus booster. Something that 99% of Americans have no idea when they're due for, right? And no ability to know how and where to go find out if they need one. But what will tell you you need that? We demand in our digital world convenience, which means that we need open APIs for scheduling. When can you see me? What is it going to cost me? How long is it going to take me to get there? Am I going to feel bad after? So we need to arm consumers with information, because if you just say it's time for you to get a tetanus booster, you could, one, miss the text, or you could ignore it altogether or forget about it, and you might get reminders. But in your mind as a consumer, it's a chore for you to go figure out where and how am I going to get this? Am I going to feel bad? What's a good, so if I'm going to feel bad, what's a convenient time for me to do it? Is this going to be expensive? We don't give consumers the basic information on shoppability that they need or availability, just like that colorectal cancer screening. Do you have to go for a colonoscopy? Or the majority of Americans do qualify for home-based colorectal cancer screenings. So if you had a choice to say, book here for next Wednesday, or click here and I can send you a kit that you can just simply mail back, you would get more people to comply by giving them choice and agency in their healthcare that we don't give them today.
That agency word is absolutely critical. I don't even think it's fully understood by the industry. Such an opportunity. You think about this transformation work that you've been involved in. If you had to kind of make a bet, who's going to really drive this transformation of our industry in the next, say, 5+ years? Who's this next wave, or about? Is it going to come from this big tech guys? Is it going to be providers? Is it going to be somebody else? I mean, who do you really see kind of taking that flag and waving and creating the incentives and driving the type of change you're talking about?
I wish that this were not a true statement, but my belief is that the federal government is going to force the change. They have to. We have, and you wouldn't, not in terms of like the builders. We have so many phenomenal builders in our country that can build the technologies. But if the incumbents and the monoliths, right, on the payer and the provider side, if we do not force their hand like we did with information blocking and interop and price transparency and provider directory, all of these transparency requirements in API, right, and now we're forcing every ACO. So we're trying to move to value-based, which is great because we can get out of the sick care system if we can do that well. But the government basically had to mandate that as part of, MIPS, that every ACO will need to be connected to every provider in its network. Those are direct data transactions. So what's happening is that the federal government is forcing connectivity, and people will only comply if there's a penalty associated with it. Because to your earlier point, it's work. And we have so much work in healthcare. And to be fair, we have a lot of work in healthcare at a time that we have a massive shortage of doctors and nurses that is only going to get significantly worse over the next decade. And with that, technology is actually the fastest way for us to scale, to see those people at scale, right? And so unfortunately, I wish that I could say that it was a tech giant. I think as more and more of these, or the incumbents, I really do wish that the incumbent monolithic technologies who have all of the knowledge around workflows and where the gaps are and the challenges with the data, like they know more, right? So you have all these new entrants that don't know healthcare the way that these guys do. These guys are trying to keep things the way that they are. These guys are like, you got to change, and we're here to help, or we're going to come, we're gonna take your cheese, right? And so, these guys can't come play unless the federal government intervenes. And they've done a phenomenal job at that over the last decade, and they don't show any signs of slowing down. But I think actually that's going to be what drives the change.
That's fascinating. And it is all about the incentives. I mean, that's what really makes or breaks change in this industry, are the incentives in place to drive it. One of the things I kind of grapple with is there's so many things that need fixing today. We've talked about a lot of them already. But if you had a magic wand and you could wave it over the industry, over our whole ecosystem, to make to give us a little bit more success in driving this future, what would be the one thing you'd point that wand at?
So it's going to sound like a very nuanced technical thing, but I think it's what actually blows open our industry for innovation in the way that it needs to. Today, our requirement, which is what they like to check a box. I meet all the requirements, right? Or I'm
no doubt.
I'm going to sell in to help you meet the requirement and check the box. I think we need to take the meaningful use certification on technology off of the system itself, and we have to put it on the APIs that interact with the system. And the reason that I say that is because it opens the door beyond data and into access APIs, so that the EHR becomes what it was truly meant to be, or the payer, even the payer system, right? This isn't just limited to provider care portals. It's all of our monolithic technologies. But if we make the certifications on the APIs, what it means is that you must share information and in a standard that allows us to start working together instead of point by point by point by point. And until we start to work together, we will never meet the demands of a consumer, and we will never keep the technology standard to where it needs to be from a privacy, safety, and security standpoint. And we will continue to build tech debt on one side and keep the innovators out on the other. And I think that is the secret sauce that's going to open up this industry to probably more advancements in a 1-year period than we've seen in a decade prior.
Well, I can't wait. I hope you're right. I hope that really drives it. That is actually very exciting. Do you have any very bold predictions for where the industry is going to be, say, in the next 5 to 10 years? Something that just is just really out there?
I think I wish anything in healthcare could be really bold in 5 years' time. I really do. And I'm an optimist by nature. So the thing that I think is going to happen in 5 years is I think consumer experience in healthcare is going to get more digitized. I think it has to. I think the demand is here. The APIs are here. I would say the transformation is already starting. Yes. But in 5 years' time, I think that's about as far as we're going to get. I do think that AI is going to come out with some breakthrough things. We're going to identify new pathways, like in my daughter's case. Her disease might get a name, and we might be able to put in for funding to try to get it raised, to try to do clinical trials and other things in order to get screening at birth for more kids. Mm-hmm. Screening at birth won't happen in 5 years, right? But if we can do that across all of the different diagnostics and diseases, I think we get a lot closer to precision healthcare, which is where we ultimately need to be. And we have the science and we have the technology to deploy it today. We have none of it. We just don't have any of the adoption.
Right. That's very fair. So we're getting close to closing, but I always kind of like to end with some rapid fire questions and just ask you to just kind of tell me first thing that comes to mind. So I'm going to start with one that, given all your recognition in the industry and your success, if you could give a founder or CEO of a new company in healthcare one bit of advice, what would that be?
There's something I wish I knew back then that I give advice to new founders all the time. It's actually twofold. One is find somebody who went right before you in the space that you're trying to get into and ask them to partner or mentor you, because a lot of times early stage founders, you get folks who are retired and want to be helpful and they've been in healthcare a really long time, and you get inundated with a lot of those folks who want to help, but they're not as current with who's the current buyer, who is the current, what's the current motivator, what are the current problems. They knew them from their time, but they don't know them today. And so find somebody who's right before you. And they certainly, by the way, and not to their fault, but because of how they grew up in technology, they are uninformed about the modern day technologies that can be utilized in healthcare for the most part. So find somebody who went right before you and partner really hard. Secondarily is healthcare it's just the revolving seats. And so healthcare is actually a fairly small world at a certain level. It is the people who come into healthcare oftentimes stay in healthcare, right? I'd say it's like the Hotel California, right? Which you can check out anytime you like, but you can never really leave. And
Yes.
you know where it's fundamentally broken, so it's hard to walk away from. And so being able to keep a contact list of every person you've ever met, and when you meet them, understand their background, their skill sets, where they've been, because that person might not be useful to you today in what you're currently working on, but inevitably they're going to change roles. And your ability to remember their skill set or call on them when you do need that skill set is going to be really, really important. And you're going to meet so many people who want to be helpful to you, but it's important to keep a log of how did you meet them? Where were they? Where are they now? And stay in touch with those that actually can help bring your innovation forward faster. And I think we just don't do a really good job at that.
That's fair. That is definitely really a great point. So, as a founder, what's the biggest or most surprising lesson that you've learned?
Oh gosh, I would say that solving the technical problems was the easy part. The real challenge is actually navigating the human elements. Right? There's a lot of entrenched interests. There's resistance to change, a lot of regulatory hurdles, and aligning incentives across stakeholders that have completely different priorities is really hard. And when you think about consumerism, you're thinking about the unification of bringing it all together, which means you have to get people with competing interests to work together at the same priority and invest the same time and money.
And that's talking about magic wands. That kind of requires.
Healthcare is a fundamentally human system. It's not a technical one.
Right. So if there were one healthcare buzzword you could retire and us never use it again, what would that be?
Patient-centered care. When it's used as an empty rhetoric. Real patient centricity requires restructuring entire business models and incentive systems. Period. Mm-hmm. So until organizations actually build financial models around actual patient outcomes rather than procedures and transactions, it's just marketing language.
Yeah, for sure. I completely 100% agree with you on that. So I'm sure you've had many of these, but do you have one proud moment at b.well that you'd like to share with us?
Oh, for sure. It actually my proudest moment, of course, was helping to pass the rules and generate the data that proves that people, can, and then turn on the technologies that prove that people can access their records. The first time I saw all of Bailey's records come in, tears came down my face, which was amazing. I would say that was probably my biggest, but my most recent was, and I didn't expect this, because when you connect technologies, and there's an assumption, there's a bias, right? That when you connect technologies like apps and wearables, and we do this through our customers, that when you turn on people's ability to get their records, you assume you're going to get the young, super healthy, or the, worry well, the people who really want to access their data. I think what makes me really proud right now, coming from a family of veterans, is the number one request we get for medical records is veterans looking for their data.
Wow. That is great. That's fantastic. That's exciting. That's great. So, you weren't working in healthcare doing this great mission and vision that you've got for b.well, what would you be doing?
I think I'd be working in education, but designing learning systems that adapt to individual cognitive patterns. I think healthcare and education are essential human systems, like we just talked about, that just haven't evolved as quickly as our technology capabilities. We are woefully behind in an area where, quite frankly, the U.S. should be leading. And both fields desperately need innovation that's grounded in human psychology. And we are not designing for humans, even though healthcare is a human business. And so I think we need to design learning systems that change the fundamentals of how healthcare works.
Well, and I'm doing some things in that regard right now with Georgia Tech, and it's very, very exciting. Can we reinvent from K to gray the way people learn? So it's kind of fun. I'm gonna close with the question I always close with because I'm always sure we've left something out. So what is the one thing that we should have talked about today that we didn't?
I think we need to talk about the urgent need for our healthcare leaders to understand behavioral economics. The gap between our technical capabilities and actual health outcomes, which we just touched on a little bit, it's explained by our failure to design systems that work with human psychology rather than against it.
Right.
So healthcare solutions that don't account for how people actually behave, not how we wish they would behave, are designed to fail. And I think that's where consumerism and digital come in. I mean, we've seen the digital revolution. We have trained people to expect incentives and in order for performing actions, yet we don't use them. So there are a number of things that we need to think about regarding behavioral economics. And I think our health system leaders really need to start to understand that if they want to truly drive the outcomes. And I think that's how we largely get the confidence that we can move from a sick care system to a value-based one, which is what we desperately need.
Oh, it's so critical because so many of the changes that we've tried to do around value, we've hung on the chassis of the old sick care system. And until we reinvent the system, we'll never get anywhere. We won't get to our ultimate goals. Well, thank you so much for your time and your thoughts today. It's fascinating. I can't wait to follow you and b.well and all that you accomplish over the next few years.
Oh, thank you so much for having me. This was a great conversation. I almost forgot we were recording.
That happens sometime.
That was
All right. Well, have a great day and good luck to your daughter. What